Good evening. A warm welcome to everyone to IIB's online Thoracoscopy certification course, which has really been creating ripples all across the country. It has been a highly successful course. As you all know, it's a certification course initiative of our Indian Association Bronchology Governing Council. And we want to make sure that IP is available to you even at your home. And that's the reason we are doing a certification course which is online. So we have 10 modules. People who want a certificate have to attend at least 8 out of 10 modules live. And after that, 4 workshops will be conducted in 4 parts of the country, north, south, east, west, on 4 different Sundays of the month. And therefore, whichever is close to you, whichever convenient to you, you need to attend any one workshop. So 8 live modules followed by 1 workshop physical, where we'll be doing so much of hands-on and showing live cases that will enable you to get your online certificate, online thoracoscopy course completion certificate. So this is the 6th module. It's a very, very interesting topic, role of thoracoscopy in undiagnosed pleural effusions and in pneumothorax. And we have a star faculty. We have our international speaker this time, the one and only, our very own Dr. Munawar, who I would like to say is practically the father of thoracoscopy. I would like to say that, though he doesn't look like a father. We have amazing faculty, which our moderator, Dr. Sushil, will be talking about. And then the webinar will take off. Dr. Sushil Jain requires no introduction whatsoever. He is head of the department of Pulmonary Ramakrishna Care Hospital, Raipur. He is the chair of endoscopic ultrasound section, WOBIP. He is, of course, governing council member of Indian Association for Bronchology. He is going to be representing IIB for us today. He is the examiner and teacher of DNB Pulmonary Medicine, and he's been immediate past chair awards committee, WOBIP. So many publications, so much more to talk about, but I'll end right now. I'll request Dr. Sushil to take over. Dr. Sushil, over to you.
Thank you, Dr. Amita. A very good evening, everyone. I'm Dr. Sushil Jain from Raipur. I'm really excited about today's webinar, which is one of the flagships of IIB. Today, we are having a webinar on role of thoracoscopy in undiagnosed pleural effusion and pneumothorax. Before we start, I want to thank IIB leadership for giving me this opportunity to be the moderator of this webinar. It's really exciting to have our first speaker, Dr. Munawar, who does not need introduction. His talk is on the role of thoracoscopy in undiagnosed pleural effusion. He's one of the most renowned and respected chest physicians and interventional pulmonologist from Lancaster Teaching Hospital, Preston, UK. He's the chair of ERS IP Group. He is the past president of European Association of Bronchology and Interventional Pulmonology, past president of BTS, and he is an editorial board of many journals, including Journal of Bronchology. He is a member of CME Endowment Committee of WABIP. So he is like, I can go on and on about his CV. I request Dr. Munawar to give his first talk on role of thoracoscopy in undiagnosed pleural effusion. Dr. Munawar, please.
Thank you very much, Sushil, for the very kind words of introduction. And thank you, Amita, Nene, and everybody involved in this outstanding initiative. I hope you can hear me clearly.
Yes.
You can hear me clearly? Okay, fantastic. I'm really truly grateful, and it's such a pleasure and privilege to be here in this webinar and share my thoughts about thoracoscopy and undiagnosed pleural effusion. This is a huge topic, but I've been given quite rightly a 20-minute slot to allow time for panel discussion. I'm going to give you headlines on this topic. This topic is incredibly important. I'm joining you from Preston, which is a small city north of Manchester, rather cold today. It started off -5 when I was setting off to the hospital. Moving to the actual topic, let me give you an example of a patient.
I'm sorry, sir. I think you need to share the slides, sir, please.
Oh, is it not coming on? Oh, thanks for informing me. That's good. Right. Can you see that now?
Yes, sir.
Okay, I'll go to slideshow mode. Can you see it now?
Yes, sir.
Perfect. Okay. Wonderful. So yes, I'm going to start off by presenting a very short case, real world case where a patient, young patient presented with left-sided chest pain, pleuritic, with a dry cough, pyrexia, and typical features of a pneumonia. Ultrasound was performed, which we normally do these days in all patients with pleural effusion on the ward. Antibiotics were given, and it appeared as though she was improving steadily. Aspiration and ultrasound guidance is performed at day 8. There were features of infection, negative cytology, AFB, gram stain, etc. And then, as the problem continued, she was referred to me from another place about nearly 3 weeks later. By this time, the patient reported to me that she was a lot better, symptoms had subsided, inflammatory markers had returned to normal. So because she gave such a positive response, we decided to simply monitor her, review her after my visit to NAPCON and Hyderabad in between. And then I saw her, and unfortunately, there was some recurrence of symptoms. And on ultrasound, there was a pleural effusion. So what would you do under the circumstances? Would you recommence antibiotics because she had such a dramatic response? Would you do a further pleural fluid assessment, or proceed to biopsy? And what technique would you adopt? Would it be ultrasound guided? Would it be thoracoscopy? Would it be VATS procedure? So that's the question. Now, what happened here was that we started off with a thoracoscopy, and this patient, you can see after the thoracoscopy, the pleural fluid was removed. The working diagnosis on thoracoscopy is a form of inflammation. Now, obviously, you're the masters of treating the most common cause of inflammation, where there is a recurrence of pleural effusion, and that turned out to be tuberculosis. Tuberculosis is one of those conditions where even a blind pleural biopsy is often sufficient because it's a diffuse inflammatory process. So if you have an undiagnosed pleural effusion, it's crucial that you get a biopsy, and you can, if you do not have access to advanced techniques, you can do still a blind pleural biopsy. However, if you look at the literature on blind pleural biopsy, and this is a study from Cape Town many years ago, comparing a randomized controlled trial comparison blind pleural biopsy with a diagnostic yield of 79% versus thoracoscopy with a diagnostic yield of 100%. Now, there are very few conditions, procedures where you will get a diagnostic yield of 100%. So without a doubt, thoracoscopy is the best possible technique for undiagnosed pleural effusion if tuberculosis is high up in the diagnostic list, because you do not want to miss a fifth of the patients by doing an alternative procedure. If you look at the latest guidelines on British Thoracic Society for pleural diseases, and this is freely available to download from the British Thoracic Society website, it takes you very systematically through the process. You've got normal history, clinical examination, chest x-ray, ultrasound, and if you suspect pleural malignancy, you do a pleural aspiration, if it's safe to do so, and you do a CT scan of the thorax. Now, the CT scan of the thorax is best done as a contrast-enhanced CT scan, preferably in the venous phase, so that you outline the pleural lining very nicely. And then you undertake a pleural aspiration under ultrasound guidance. Usual things that you send for, including microbiology, biochemistry, and cytology. I'm just going through this bit rather fast because it's very basic for all of you. And then you decide whether you're going to do an image-guided pleural biopsy or thoracoscopy. In certain situations, you might do more specialized tests with regard to evaluation of the pleural fluid. If you were to summarize and constrict that, the pleural effusion, undiagnosed pleural effusion, you want to exclude it, a transudate, first of all. You want to exclude an empyema. Then you do a contrast-enhanced CT scan, and without a doubt, the best next procedure would be a thoracoscopy for many reasons. One, very high diagnostic yield. Two, because thoracoscopy allows you to drain the fluid in its entirety. And finally, if appropriate, you would even be able to do a pudrage all in one sitting, about 30 to 40 minutes, and you've done a complete procedure with a very high diagnostic yield. An alternative, if the patient is not suitable for thoracoscopy, or if you do not have thoracoscopy, would be to do an image-guided pleural biopsy and then drain the fluid. provided the patient is fit. And actually, thoracoscopy has been around for more than 100 years, thanks to Jacobius, who did the maximum amount of work with regard to thoracoscopy. He was a physician and internist in Sweden who introduced a cystoscope into the pleural cavity and noticed that the views were really good. And at that time, because anti-TB treatment was not available, he was also able to break down the adhesion with very good success rate, something which came to be known famously as the Jacobius operation. Thoracoscopy world over is practiced traditionally, and this is more than a century now, with a rigid thoracoscope. And this rigid thoracoscope gives us a diagnostic yield of over 95%. Without a doubt, it is the most extensively used equipment around the world. Even in patients with previous negative pleural biopsy, you still get a very high diagnostic yield with this technique. So that is the rigid thoracoscope, which I'm sure you would have seen, and its use. There are alternatives available these days. In the last 20 years, we have available to us a semi-rigid thoracoscope or a flexi-rigid thoracoscope. And this very nice meta-analysis from Ritesh Agarwal's team from PGI Chandigarh showed two things. One, very high sensitivity, very high diagnostic yield, and two, safety, emphasize the safety because complications were negligible and mortality was virtually none. So this is the semi-rigid thoracoscope. More recently, a mini thoracoscope, and again, an elegant study carried out by Karan Madan and group from All India Institute, New Delhi, called the MINT trial, showed that this mini thoracoscope, often referred to as the egg scope, can also be used for this purpose in undiagnosed pleural effusion. So whatever you have available to us. And in the future, hopefully, shortly, you will have access to this next generation flexi-rigid thoracoscope called the H290. What is different about this scope? First of all, very high definition that you see in this HD imaging. Secondly, the angulation of the scope is upward up to 180 degrees, which means you can actually see the entry point, which you can't do with any other thoracoscope. And then you have narrow band imaging capability and a larger working channel of 3 millimeter. So all of this can be used to get you very superior images, as you see here, this example, where you can see some infiltrative disease in the pleura. This is the lung. For those who have not performed thoracoscopy, you can go around the pleural cavity in a matter of seconds and do a complete examination. This is the diaphragm that is coming into view, the costophrenic angle, the Cru ray that you can see, and then back to the lung. So all of this can be done. Now, if you see with regard to a semi-rigid thoracoscope, you can see the new thoracoscope. If you have a look with the new system, the EVIS X1, which is available along with this thoracoscope, you can get, besides narrowband imaging, you can do something called texture enhancement imaging, TXI, and something completely novel called RDI, red dichromatic imaging. What is the use of this? You can see deeper vessels. So just in case you're planning to take a biopsy and it's not obvious infiltrative disease, then you can utilize this to ensure that you're taking the biopsy safely and away from the area of where the blood vessels are. So in short, thoracoscopes are available for undiagnosed pleural effusion, a wide variety of available to you. There are pros and cons of each. You can pick and choose what you can afford and do the procedure. Thoracoscopy is one of the important points, a lesson to be learned from this particular slide is if you have an undiagnosed pleural effusion, the worst thing that you can do is to put in a chest drain. You should not without a diagnosis, unless you confirm that it's an empyema, for instance. Otherwise, you should take that systematic approach that you have described, because if you put in a chest drain, it messes up the pleural cavity. And then if you do thoracoscopy or any procedure, you won't get very clear images. So in short, the most common indication for thoracoscopy is what we are discussing today: unilateral, undiagnosed, exudative effusion. So you can complete all that is necessary during the procedure in one sitting. There are some contraindications to remember. The most common or most important absolute contraindication is when the lung is completely adherent to the chest wall throughout the hemothorax. Other contraindications are relative. This is available in the British Thoracic Society website. So in the interest of time, I won't go through in detail, but just remember that the patient should be able to consent, patient should be comfortable during the procedure, because this is an invasive procedure, admittedly a minimally invasive procedure, a keyhole procedure. Nevertheless, it's important the patient needs to be comfortable. The most important safety measure with undiagnosed pleural effusion when you're doing thoracoscopy for that purpose is ultrasound. So you choose the spot, you make sure the diaphragm is out of the way, you ensure that there is adequate fluid, you judge the depth of the fluid so that you know how far to introduce a needle and your trocar and cannula. The next important point in thoracoscopy for this purpose is to ensure always that it is completely sterile around the procedure site where your entry point, because the pleural cavity is completely sterile. So introducing infection is the worst possible thing that you can do. I talked about comfort, about the importance of sedation and local anesthesia. Both are necessary in thoracoscopy, both sedation and local anesthesia. Sometimes we also use general anesthesia, but it's uncommon. And then step by step, and this is for another talk, which I think is being covered already in another part of this online module, but step by step to perform thoracoscopy, you need to learn about blunt dissection, about trocar insertion, etc. Moving on, just to give you some of the things that you might see during thoracoscopy, this is a pleural plaque, a classical pleural plaque, the whitest pleural plaque that you see. And this you may be more familiar in our country, in India, because multiple nodules of this nature or diffuse thickening is often due to tuberculosis, as was the case in this patient who was visiting from India and came to Preston in the UK. Now, a few other points when you're doing thoracoscopy in undiagnosed pleural effusion, you need to be certain, having done an invasive procedure, that you get maximum possible representative samples. So for this, you should be able to take big enough biopsy samples. So if you have nodules like this, then you can simply introduce a biopsy forceps and pluck the nodules just as you would do during bronchoscopy. However, if you have diffuse thickening like this, then it is absolutely crucial that you pinch and peel very carefully. Take your time, pinch the nodule, and then peel. So the next biopsy that you take, you would go to the edge of the pleura, edge of where you've already taken a sample, and then you peel some more tissue after pinching into the edge. So this technique is important, and the right biopsy forceps is also important for you to use, a larger biopsy forceps for this purpose. Occasionally, when there is diffuse thickening and you can't get big enough samples with biopsy, very occasionally, and if you are experienced, your team is experienced with the use of a cryobiopsy probe, then you can do a cryobiopsy, as is being demonstrated by Aleš Rozman, who is an expert in the field from Slovenia. So there is a small role in this undiagnosed pleural effusion. And finally, of course, in this patient, in undiagnosed pleural effusion, in some situations where you're fairly certain that this is malignancy, you can spray talc at the same time at the end of the procedure. And talc is available in different forms. This particular form of talc is available in India now, I gather. So this is something which comes to in one kit, and you can use it and spray around the pleural cavity in a matter of minutes. Just a few final points. Sometimes we also place an indwelling pleural catheter at the end of the procedure after putting the talc in. And this is the subject of a trial, which we can talk about later if there is time, which we are conducting or just finished recruitment in the UK. And thoracoscopy can also be done as a day case procedure. Huge advantage of thoracoscopy. You can do the procedure in the morning, observe in the afternoon, take out the drain in the evening and send the patient home, provided they are quite close to the hospital, have support if there is a problem. But actually, this study has shown that it's safe if it's conducted in a systematic manner as a day case procedure. In small undiagnosed pleural effusion also, there may be a role for thoracoscopy. In this situation, you have to induce a pneumothorax, you have to be experienced in ultrasound, induction of pneumothorax. This is an advanced level of thoracoscopy. So safely that is possible. For this, you need to have a good knowledge of ultrasound. You should be able to appreciate the sliding sign so that you know that once you induce the pneumothorax, the lung is going to fall away and provide you with adequate space. So recognizing the sliding sign, recognizing also the presence or absence of blood vessels on ultrasound will be important if you wish to go down this route. Finally, if you wish to do a thoracoscopy, if you want to learn thoracoscopy, it's important to learn ultrasound, important to start with a larger effusion where it's completely safe to enter the pleural cavity and then perform the procedure. So in conclusion, thoracoscopy is a simple, safe, highly successful procedure when it comes to sufficient samples, provided you have had systematic training, select the patients carefully, ensure that it's sterile, the field, ensure that the patient is comfortable with adequate sedation and analgesia. With training, only specialist operators. We want the patient to be safe. And for safety, it is crucial that you perform ultrasound on the table. So one of the most effective techniques in pulmonary medicine now is thoracoscopy. Most useful techniques besides ultrasound, besides bronchoscopy, besides EBUS, thoracoscopy figures very highly. Ultrasound, you also look at the sliding sign. You have to be prepared. Bleeding is exceedingly rare in thoracoscopy if you follow this systematic approach, but you have to be prepared. Prepared to deal with the bleeding should it occur, and also have a very close collaborative working relationship with your thoracic surgeon. Thank you very much indeed for your kind attention.
Thank you, Dr. Munawar. This was really a very elaborative and very nice talk from you. We'll have the questions after both the talks. So I will go on to our next talk by my dear friend, Dr. Vijay Chennamachetty. He is a senior consultant interventional pulmonologist and sleep disorder specialist from Apollo Health City campus, Jubilee Hills, Hyderabad. He has a special interest in interventional pulmonology with focus on thoracoscopy. He is one of the very well-known and renowned pulmonologists from India, and he'll be giving his next talk on role of thoracoscopy in pneumothorax. Dr. Vijay.
Sushil, thank you so much for that nice and warm introduction. And I must thank Amita and an entire IAB core team for having me here. And I feel somewhat nervous after listening to Munawar sir. And I feel also simultaneously very honored to give talk subsequent after Munawar sir. Sir, that was a fantastic talk, sir. Okay. Every time you give a talk, we learn a lot from it, sir. Thank you, sir. And next 20 minutes or so, okay, I'll discuss about what is the role of thoracoscopy in pneumothorax. I bring very, very warm wishes from Apollo Hyderabad, the hospital where I work. And disclaimer for all the young students or young practicing pulmonologists is, I have been practicing thoracoscopy for the past more than 15 years. And I have worked with at least close to a dozen surgeons. And I learned acquired skills from these surgeons. So I may be showing very important videos, and they may require a lot of skill. So please do not, seeing is not everything. Okay, hands-on experience is everything. And then don't try to imitate the same skills without any seniors presence That's most important. And few of the slides I may skip because, okay, Dr. Munawar sir has already spoken about those slides. Jacobius is, as said by Dr. Munawar sir, okay, he is considered as a father of thoracoscopy, as with very, very vast experience. Outline will be classification of pneumothorax, and I will be dealing predominantly on primary spontaneous pneumothorax and how to quantify investigations and treatment options and interesting case to close with. So pneumothorax is classified as spontaneous, primary and secondary, and traumatic and tension pneumothorax. And generally, primary spontaneous pneumothorax is developed with in individuals with no underlying lung disease. And most common etiology remaining the rupture of subpleural and emphysematous blood. Cigarette smoking is known as a very, very known risk factor, notorious risk factor. Generally occurs in taller and thinner individuals where the gradient of pleural pressure is more in lung apex than in the base, which results in more mean descending pressure in the apex, leading to pneumothorax. Subpleural blood usually defined as evidenced in the CT and then thoracoscopic image, which is less than 1 centimeter. Generally, it is seen in the apex. Genetic predispositions like Bret-Hogg-Dubé syndrome, Marfan syndrome, homocystinuria, and Ehlers-Danlos and alpha-1 antitrypsin deficiencies can result in pneumothorax. And then various bronchial abnormalities can also lead to pneumothorax, like disproportionate bronchial anatomy, accessory bronchus, missing bronchus. Looking at the primary spontaneous incidence, it is generally more often seen in males than in females. And as discussed, usually occurs in tall and thin individuals, generally between age 10 and 30 years. And usually occurs at rest. And there are some precipitating factors like change in atmospheric pressure and emotional change. Valsalva maneuver or hearing loud music can also lead to precipitation of rupture of these bloods. When we look at the pathophysiology, eosinophilic pleuritis and mild pulmonary vascular and perivascular eosinophilia is observed in the biopsied specimens. Pulmonary arterial intimal fibrosis and pulmonary vein intimal fibrosis was also noted in the pathology. Quickly, I'll go through clinical diagnosis, physical examination very quickly to give a overall shape to it. Physical examination, vital signs are usually normal except for there may be moderate tachypnea. And this tachypnea is a result of stimulation of various receptors like chemoreceptors, deflation receptors, irritant receptors, J receptors. Can also result from pain and anxiety. And on clinical examination, hyporesonant percussion is very, very important, particularly both in bedbound patients and also in otherwise patients. Elicitation of hyporesonant percussion note is very, very important in diagnosing if you don't have any other gadget to diagnose. And chest X-ray, how to stage. There are various methods to stage, like Collins method, Rias method. And the most easy thing is BTS guidelines and ACCP guidelines. BTS guidelines defines small pneumothorax as a rim of air between pleura and chest wall at the level of hilum and is less than 2 centimeters. It defines large when it is greater than 2 centimeters. According to ACCP guidelines, small pneumothorax is defined as from apex to cupola distance is less than 3 centimeters. And if it is more than 3 centimeters, it defines it as a large pneumothorax. Generally, CT chest shows in primary spontaneous pneumothorax, there is a lot of pleural blebs. And it also helps us in identifying to localize bullae and blebs in multiple areas. And then when we get into the pleural space, to look for through thoracoscopy, these blebs, it will help. As per the Van der Schuren classification, there are various stages. The first one, stage 1 is absolutely anatomical normal picture in thoracoscopy, whereas stage 2, there will be pleuropulmonary adhesions, and stage 3, blebs less than 2 centimeter, whereas stage 4, blebs greater than 2 centimeters. What is the role of fluorescent enhanced autofluorescence thoracoscopy? So in this, the subjects were asked to inhale a aerosolized 10% fluorescent solution and then underwent thoracoscopy using a DAF autofluorescence endoscopic unit. So what is important to identify is the extensive subpleural accumulation of fluorescent leakage, which corresponds to high-grade lesions, which will be appreciated in primary spontaneous pneumothorax patients. And what we need to understand from this is, these lesions did not necessarily correspond to the bleb, bullae, or other lesions visualized under white light thoracoscopy. This also means that just excision of bleb and bullae is not only is needed. So, because the adjacent visceral pleura also shows the fluorescent leakage. So that's why, so just blebectomy or bullectomy is not the choice. We have to do more to decrease the recurrence of pneumothorax in these patients. And coming to the question to all of you is, see, what is the most important skill that one need to have while managing a pneumothorax patient? Is it needle aspiration? Is it ICD placement? Is it thoracoscopy? Or is it VATS? Or refer to a friend or other pulmonologists? Because when I was training in pulmonology, so what our seniors used to tell is, presence of any air leak, persistent air leak in pneumothorax patient, it is like pain in neck. So better to refer to a colleague pulmonologist who doesn't, who is not really friendly to you, because it is very, very difficult to manage in those days. But in the past 2 decades, there is a lot of advances in technology so that we can handle exceptionally well these cases. So there is no need to refer to any other pulmonologists. So what is the most important skill? The most important skill is what Buddha said: there is no error greater than hatred and nothing mightier than patience. So I strive in every way to learn patience. So the most important skill while we want to manage pneumothorax is learn to be very, very patient enough. Every patient may not be a very smooth case. Patient may develop some complications, patient may develop recurrences, and you need to deal with these patients with lot of patience. So coming to thoracoscopy for spontaneous pneumothorax, so a recent meta-analysis published in Journal of Clinical Medicine, which said 29 studies comprising more than 13,500 adult patients with the first episode of primary spontaneous pneumothorax found that approximately 30% experienced recurrence within first year, and females were at higher risk. Of close to 170,000 hospital admissions in England for spontaneous pneumothorax, 61% of patients had a chronic lung disease, and the recurrence rates were higher in secondary spontaneous pneumothorax than compared to primary spontaneous pneumothorax. What is important here is, once a patient starts developing recurrence, the subsequent recurrences were even more common. So what are the general treatment guidelines? If you look at the initiation of treatment of spontaneous pneumothorax, so look at this table where A to F, all these cases were in primary spontaneous pneumothorax. In primary spontaneous pneumothorax, even if there is no dyspnea and it is a very small size on chest radiograph, it's just you observe this patient with supplemental oxygen. And in cases where dyspnea is there and large size of X-ray, then probably needle aspiration plus or minus chest catheter tube. In patients where severe dyspnea and hemodynamic instability, obviously we will end up in placing a chest tube. In patients with bilateral spontaneous pneumothorax, make sure you handle with chest tube at the presentation itself. In patients with no resolution after observation or needle aspiration, obviously have to be dealt with chest tube. And in patients associated with pleural effusion, again you need to place a chest tube. And in case of recurrent primary spontaneous pneumothorax, it is very, very important to place a chest tube and then shift over to consider for a definitive therapy. In secondary spontaneous pneumothorax, always it is important. There is no need to wait or just supplement oxygen and then see, or needle drainage. It is always important to place a chest catheter or tube. It is very, very important. So, should thoracoscopy surgery should be offered for every first episode of primary spontaneous pneumothorax? It is very, very important. So, which patients that we should consider for primary thoracoscopy in the first episode itself? The guidelines were very clear, and tension pneumothorax and those with persistent air leak beyond 5 days, high-risk professions or hobbies, such as those are airline pilots, divers, and sailors. And those patients who presented with bilateral pneumothorax, patients who desire for definitive therapy, and concomitant indication for thoracoscopies like presence of associated pleural effusions. So these are the cases where even if the primary spontaneous pneumothorax is first episode, you would consider for a thoracoscopy. And all cases of second episode of a recurrence of primary spontaneous pneumothorax and secondary spontaneous pneumothorax, all cases, it is indicated that a thoracoscopy should be considered. And remember, the treatment aims at to rid the pleural space of its air and also to decrease the chance of recurrence. And what is the difference between medical thoracoscopy and surgical thoracoscopy? Medical thoracoscopy we perform, and then probably the experienced pulmonologists can also perform VATS to some extent. That's what I practice. And thoracic surgeon generally practice VATS. And location-wise, generally the thoracoscopy can be performed in endoscopy unit or operating room. VATS always in operating room. Anesthesia, local and conscious sedation for MT, whereas single lung ventilation, general anesthesia with W tube is recommended and it is needed for VATS. Entry ports generally one in medical thoracoscopy, whereas in VATS, either it is uniportal or biportal or 3 ports. Instruments, either rigid, flexi-rigid, mini thoracoscopy is indicated in medical thoracoscopy, whereas in VATS, it is always rigid. Technical variants and what is available is mini thoracoscopy, flexi-rigid thoracoscopy is available, whereas here uniportal, needle scopic and non-intubated VATS is being available. So what we need to understand is when patients with primary spontaneous pneumothorax were subjected to VATS in the first instant as well. So number needed to treat to prevent one recurrence is 3 patients. That means invariably the 2 other patients which were underwent the VATS were in these clinical scenarios we are overdoing the VATS. So that's why it is said that it's only the recurrence of primary spontaneous pneumothorax and other indications as discussed should be addressed with VATS. Various other modalities to treat is primary spontaneous pneumothorax is observation, supplemental oxygen, aspiration, tube thoracostomy, and after placing an ICD. So if the patient develops tension pneumothorax, what are the various clinical scenarios? The commonest thing is the ICD is being clamped. This is one of the commonest mistake that we do see in some centers. ICD would have been clamped, or this white knob on the Romodrain bottle would have been, the cap would have not been removed. So that's why, the tension pneumothorax occurred in this case. just removal of the clamp and taking off this white cap of this Romo-drain bottle would suffice to manage this tension pneumothorax. Sometimes sclerosing agents we give, including autologous blood patch, and very rarely open thoracotomy is also is recommended. And looking at whether VATS or medical thoracoscopy, again, the surgical management of spontaneous is typically reserved for VATS. It might rarely be performed by skilled proceduralists using medical thoracoscopy as well. For instance, in one study where 124 patients with primary spontaneous pneumothorax underwent electrocoagulation of blebs and bullae and tall Woodridge pleurodesis under medical thoracoscopy. Look at the mean operative time in case of exceptionally skilled pulmonologists. It was only 15 minutes. And 3% of these patients required reoperation. Only 3%, hardly 3% of patients required the reoperation by axillary thoracotomy approach. So coming to pleurodesis, various agents we use for pleurodesis. There is no consensus on the best treatment of blebs and bullae except when they are leaking, nor on the ideal method of pleurodesis. In patients who are inoperable or refuse surgery, besides pleurodesis, via bedside pleurodesis via ICD is recommended. Recurrences following VATS can be managed with redo VATS. And next 4-5 minutes, I'll present this case, interesting case, and then close the my presentation. This is regarding a 28-year-old male with no comorbidities, presented with sudden onset of grade 3 shortness of breath, right side chest pain, with no fever, no trauma, not a smoker, and history of similar complaints 1 year back, for which he underwent tube thoracostomy on right side. Young, lean, respiratory system was suggestive of right side pneumothorax. Examination was suggestive. Even X-ray was suggestive of pneumothorax. And based on clinical history, the provisional diagnosis of recurrent primary spontaneous pneumothorax has been made. And this is what CT chest showed. If you carefully look in the right upper lobe posterior aspect, there is a bleb available. And patient became symptomatically better after placing ICD, but the leak was evident. And upon examining the pleural space in thoracoscopy, so there were adhesions. These adhesions may be because of the previous intercostal tube drainage placement. So it is very, very important to focus all along the pleural cavity, pleural space, and carefully look at the apex where this is the area. It is showing a ruptured bleb here. This is the area where the bleb was there and it was ruptured, that led to the recurrence of the pneumothorax. And as I mentioned, I practice two-port technique for managing pneumothorax. And second port should always be placed under the vision. So, and generally here I place with a sharp trocar, but I suggest beginners to use only blunt trocars, while trocar and cannulas to place the port. And what I did in this case is, so using a long cautery, so I have created a lot of abrasions along the intercostal space. And these abrasions will help in forming the pleurodesis, parietal pleural abrasions. And following creating parietal pleural abrasions, talc pudrage has been done with steri-talc. And even evidence says that the combining, it's not that blebectomy or bullectomy alone should be offered. It's a combination of techniques like mechanical abrasion along with the talc pudrage, and then if there is any bleb, Okay, if it is a small bleb, you don't need to do a blebectomy. So these are, and then post-op. This is a CT and post-op. So post-procedure chest X-ray was showing good expansion, no residual pneumothorax, hence ICD removed. Patient became symptomatically better. So that's how a combination of mechanical pleurodesis using electrocautery along with the talc portage. That's how I manage this case. And take home message from my view is primary spontaneous or secondary spontaneous pneumothorax, which we have discussed, and quantification methods I discussed, various treatment options discussed, and don't want to handle, if you feel that you are very beginner enough, please refer to a colleague. And whenever you are doing a thoracoscopic procedure, as Dr. Munawar said rightly, please inform your thoracic surgeon, make your thoracic surgeon as a best friend, because once in a blue moon, very rarely, you will experience bleeding as a complication when you are doing these advanced procedures. So during that time, it is very, very important that your surgeon is going to bail you out. So please keep this in your mind. Early intervention might give you better outcomes, including cost savings. And finally, you need to have lot of patience while dealing pneumothorax and persistent leaks, which will your patience is going to save you a lot. Thank you, and over to Sushil.
Thank you, Vijay, for the extraordinarily good talk. You have really presented it very well. Now we move on to our next part of our webinar, where we will have a panel discussion with three of our panelists, eminent pulmonologists from across the country, along with the two speakers. Our first panelist is Dr. Praveen Valsala. He is the lead consultant interventional pulmonologist at Aster Medicity, Kochi. He is an examiner and teacher for DNB Pulmonary Medicine and MRCP basis exams. Our next panelist is Dr. Shweta Bansal. Again, a very senior pulmonologist and unit head at the Department of Pulmonary and Sleep Medicine at Narayana Super Specialty Hospital, Gurugram. Our third panelist is Dr. Arpan Shah. He is a consultant pulmonologist and medical director at Pranayam Lung and Heart Institute, Baroda. He is the first. He has started the first IP unit at Gujarat. Arpan has been doing a lot of interventions for a long time. And now we will start a panel discussion. My first question to our panelists, Dr. Praveen. What are the minimum investigation? I would rather say, what are the optimum investigation you should send for any pleural effusion requiring a TAP? Dr. Praveen, please.
Hi. Warm good evening to one and all. And thank you, the organizers, for giving me the opportunity for me to be here in front of this esteemed audience. When we do a pleural tapping, or what we call as a thoracocentesis, there are a few things, which we need to be, very careful about. The first and foremost is to see what type of fluid it is, whether it is a transudate or an exudate. So to know that, we need to send for the protein, the sugar, and the LDH. And we all know the Light's criteria. The protein, the pleural fluid protein more than 0.5, or the LDH more than 0.6, and the two-thirds of the more than two-thirds of the serum LDH, that constitutes an exudate. Further, we need to see the total count and the differential count of the pleural fluid. So the total count can give an idea whether it is an synemonic effusion, or the differential count, like say if you say it's a lymphocytic effusion, then probably it can give a clue about what the background thing is, like say tuberculosis. If it is a neutrophilic, probably it could be an synemonic effusion. We should send the pleural fluid for an adenosine deaminase. Again, positivity can indicate that it could be secondary to tuberculosis. Of course, we should send the fluid for culture and sensitivity to look for what the bacterial bug is. It should also be sent for, in our scenario, should send it for an CBNAT or a gene expert for Mycobacterium tuberculosis. Even though and preferably for the culture too. In fact, in our setting and all, we have a single order, like it's called the TB diagnostic panel, where when we send it, it goes for whatever the thing is, whatever the sample is, it goes automatically for the gene expert, its smear and the culture. Then if you're thinking in terms of a fungal infection, when we can send it for a fungal smear or a culture. Very importantly, we should send it for a cytology to look for any malignant cells or any other thing is there or not. Then if you are thinking, these are the most common things that we need to send it. If you're thinking like, say, if it's a pneumothorax, then probably you should send it for a hematocrit and then PCV. If it's like, say, if you're thinking in terms of a chylothorax, then send it for an chylomicrons or triglycerides and like say, or if it's a pseudochylothorax, then look at the cholesterol levels and etc. etc. But the above ones are the basic things that we should send when we do a thoracosynthesis.
Thank you, Dr. Praveen. Do you think that gene export should be done in pleural fluid because they have much lesser yield in pleural effusion?
Yeah. Yes.
Not recommended
yes,
usually in
definitely.
most of the guidelines.
Yeah, we generally don't do it because it's all usually associated along with that. The pleural biopsy will be done. So pleural biopsy gives a much better yield. This hardly gives around 20 to 30% yield.
Yeah, for tissue, yes, you can, but for pleural effusion, usually we don't do it. Thank you, Dr. Praveen. Now we move on to our next panelist, Dr. Shweta Bansal. The question was, according to you, what qualifies as an undiagnosed pleural effusion? That's a very important question. Which are the patients you consider as the case of undiagnosed pleural effusion? Dr. Shweta.
Yeah, thank you so much, sir, and good evening to everyone. We call a pleural effusion to be undiagnosed when when there is a diagnostic dilemma and when we are not able to reach the etiology of the pleural effusion after the basic investigations, which Dr. Praveen has said. After doing a thorough history and taking thorough history of the patient, clinical examination of the patient, and doing the imaging, which may consist of the chest x-ray, the ultrasound and the CT scans, and you have done the thoracocentesis. You may have already sent 2 to 3 cytologies and other tests which consist of biochemical and microbiological tests. After all these basic investigations, which may also include sometimes a closed pleural biopsy also, you are not able to reach the diagnosis. And the most common scenario that we encounter is the undiagnosed exudative pleural effusions. Like in India, where TB and malignancy is very common, we do commonly find patients who are exudative. The pleural fluid is exudative, lymphocytic predominance, maybe 95% lymphos are there, and still the ADA is maybe borderline, maybe low. So the patient has been smoker, patient is aged, there is 2 to 3 weeks of history. So you are always in dilemma, whether it's TB or malignancy. You have done ultrasound, you have done CT scans, there is just a pleural effusion on the HRCT. So after these basic investigations, you are still not able to reach your diagnosis, you are still confused. So this is what we call as undiagnosed pleural effusion, and approximately 25 to 40% are there. 25% of the pleural effusions remain undiagnosed after this all these investigations and on the basis of the clinical and physical examination and imaging. So in such patients, we do need to go further, maybe in terms of the medical thoracoscopy or further imaging and further investigations. Histological confirmation is needed.
Thank you, Dr. Shweta. Mainly these effusions are exudative effusions and we are not having a conclusive diagnosis, then we move on with the thoracoscopy. Usually transudative effusion, we usually don't go for a medical thoracoscopy. That's what is the message we want to give to our listeners. I think we move on to the next question to Dr. Arpan Shah. How do you approach a patient of undiagnosed pleural effusion? What is your clinical approach in patients with undiagnosed pleural effusion? Dr. Arpan.
Good evening, everyone. Thank you, sir, for these questions. See, Dr. Praveen and Dr. Shweta has already pointed out the basic tests that are needed. I'll just put one point out here that check the albumin gradient, because 20% of transudative effusions would, according to light criteria, will be showing an exudative. So whenever clinically you are suspecting a transudative effusion and the light criteria is showing an exudative effusion, check for the albumin gradient, which has to be more than 1.2. So that is one thing which is a non-invasive one. And the big boss of thoracoscopy is with us right now. Munawar sir is here. He's already pointed out in his talks. See, ideal case would be to get in unilateral undiagnosed pleural effusions. Ideal case would be get the tissue diagnosis. It all depends on where you're practicing and what all facilities you have. On a lighter note, if I talk about our institute, my father used to practice with an abdomen sponge or a Pope's needle. My brother, the younger brother, is trained on thoracoscopies. I was the one sandwiched between the two. So use both of them as and when required. So it all depends on where you're practicing, what is available to you. But medical thoracoscopy is an ideal thing. Two things here I would like to point out. Sir pointed out about the new scopes, 190 that is available out there. It's slowly coming to India as well. So it takes care of that blind spot which was there on the point of entry. So that would also help us in giving a better yield for that. Other thing that we do at our center is that wherever we are suspecting in an undiagnosed unilateral pleural effusions, kind of a long-standing ones where we are suspecting kind of an empyema, we use a single port rigid thoracoscope as well. So going in, we take a decision on whether we'll be going through a semi-rigid thoracoscope or a single port rigid thoracoscope, where we are suspecting a lot of septations or adhesions.
Thank you, Arpan. I think here I would like to suggest that if there are a lot of adhesions and septations, then probably it's a place for a surgeon. If there are early empyema or less adhesions, then maybe medical thoracoscopy may help. So for advanced empymas, probably send it to a surgeon if you're seeing a lot of adhesion and septation.
We've been doing it quite often. So because of our backup things, and it's kind of a gray zone area. So I would not advise or suggest that for it's just a gray zone area.
People will start jumping for advanced empyema. So I think if it is there are a lot of adhesion and septation, better to send a surgeon. Early empyema, yes, a place for medical thoracoscopy. That's what all the guidelines say. I think most of us agree with it. And there are certain good interventional pulmonologists are doing advanced procedures, but I think here we are limiting ourselves to only evidence-based and for the beginners. So let us stick to the basics. Now, next question is Dr. Munawar. Sir, this is for you. Do you plan pleurodesis in the same setting as biopsy in patients with undiagnosed pleural effusion? Do you do that or you don't? Hello? Dr. Munawar?
Yeah, thank you, Sushil. Very good and very practical question. Yes, we do, depending upon the pre-test probability of it being a malignant pleural effusion. So pre-test probability will depend upon the appearance of on CT scan, appearance on ultrasound, and thoracoscopic appearances. And the advantage of doing pleurodesis at the same time is to ensure that you do a complete procedure. So you do the pleurodesis, you drain the effusion to dryness, and within a couple of hours, 3-4 hours, if the lung has totally expanded, you could remove the drain and send the patient home potentially. The disadvantage, particularly in an Indian context, is the possibility that you have a patient who looks like malignancy but turns out to be tuberculosis. Something you need to bear in mind. Now, in advanced centers, I'm aware of some centers in India who have the luxury of a frozen section at the time of the procedure, or you have imprint cytology or something similar to tell you whether this is malignancy or not. In the past, what we used to do is to try very hard to try and complete pleurodesis, do pewterized at the same setting. However, more recently, the TAPS trial, which was a UK multi-center trial, showed that there was no statistically significant difference between introducing talc during thoracoscopy and introducing talc slurry on the ward after the patient goes to the ward, success rate-wise. So what we tend to do now If the pretest probability and we are fairly certain that this is malignancy, then we would do pleurodesis. Otherwise, we would, if we don't have frozen section, that is, we would send the patient, not do pleurodesis, but send the patient back to the ward, ring the lab, and ask for an urgent, fast-track result just to say whether this is malignant cells or not, and then put in the talc slurry on the ward. So that's how we practice. So these are points you need to bear in mind. Of course, in the Indian setting, always TB is a possibility, so you've got to be extra cautious. Thank you.
I think that's really good. We also do the same thing, that if we are not very certain that it's TB or malignancy, better send the patient to the ward with ICD, get an early histopath. Maybe you can keep the patient for a day or two, and then you do a talc drug through the ICD. I think that's a better approach, because sometimes we have seen that we thought that it was a malignant lesion, but it turns out to be a benign lesion like TB. So I think that's in Indian setting, that may be interesting. I think that is important for us.
Just one other point, Sushil, on that topic. Just one other point is that in the Indian setting in particular, if you can get a fast-track PCR result on the biopsy to exclude or include TB, that may also be beneficial. Thank you.
Yeah, thank you. Thank you, Dr. Munawar. Now we move on to our next question. Dr. Praveen, would you prefer to go for image-guided biopsy versus thoracoscopic biopsy on undiagnosed pleural effusion? What is your approach for that? On which other cases do you consider either of them?
Okay, so that's a question which is basically looking at the clinical situation, or where you're working, and the expertise and the cost and the location where and the facilities that you have and things like that. Very importantly. But said and done, the image-guided biopsy as well as the thoracoscopy has its own pros and cons. So if you look at the image-guided biopsy, it's probably cheap, readily accessible, and minimal consumables. It's much less invasive. OP-based procedure, the patient can be discharged after a few hours of observation. And situations like if there is a pleural thickening and there's hardly any effusion, then probably an image-guided biopsy will be an ideal thing to do. And less sedation, much less sedation, as it's like a daycare procedure, and discharge within a short period of observation. And that's advantage of an image-guided biopsy, but it has its own disadvantages. So the disadvantage is disadvantage of the image-guided biopsy is actually the advantage of the thoracoscopy. That probably the most important thing is what Dr. Munawar sir has already mentioned, that probably we can do the diagnostic and therapeutic in a single setting. So that's a huge advantage of. The second, the other uses being that we can do a large volume thoracocentesis without much fear of re-expansion pulmonary edema. In a thoracoscopy, we are doing it under vision, direct visualization. So we are taking the biopsy from where we want to do it and where we see the lesions are. So multiple biopsies can easily be taken from the areas where we want to do it. And even in many inaccessible location, like for example, image-guided biopsy, if there is a rib and if there is something under the rib, probably it might be a little bit difficult. And there are situations like that. So those sort of things can be obviated in a thoracoscopy. The other advantages being, we can do as I already mentioned, we can do the pleurodesis along with that. So talc prodrug can be done immediately. But then thoracoscopy also has its own disadvantages. We require a thoracoscopic suit, and we require a slightly more advanced anesthesia and analgesia, slightly more longer time. But then, like in India, we may not discharge all the patients on the day itself. Many of the time they might stay for 1 or 2 days, but so that sort of the longer stay, so the longer the cost, the higher the cost, and some complications like the persistent BPF, persistent air leaks, occasionally the hemorrhage, the port site tumor growth, etc. So all these are the complications of a thoracoscopy itself. So it all boils down to the choice and the expertise that we have and the facilities that we have. So if we are given an option, if it's a very peripheral hue, if it's like a thick pleural thickening, probably and without much effusion, then probably an image guided biopsy is more than enough. But if there is a lot of effusion, then it's always better to go in for a thoracoscopy and then take a sample out of it.
Thank you, Dr. Praveen. I think nowadays we are gradually moving towards more and more thoracoscopic biopsies rather than going for image guided. Only very few selected patients usually we do go for a image guided biopsy, which you already mentioned. I think now we move on to our next question to Dr. Shweta. Does thoracoscopy ever fail to answer the questions of diagnosis? And what can you do to increase the yield of thoracoscopic procedure? Dr. Shweta, please.
Yes, definitely. No test is 100% has 100% diagnostic yield. Even medical thoracoscopy, if we see the diagnostic yield in malignancy, may be up to 95%, and in tuberculosis, yes, the yield may be more than 90%, reaching up to 100% as well. But still, there are 5 to 10% of the cases which may still remain undiagnosed after medical thoracoscopies, which may be because of various reasons. First of all, the patient selection was not proper. Maybe the fluid was not adequate enough. You had not done the pre-procedural ultrasound. There were a lot of adhesions there. And when you entered, because of adhesions, you were not able to take the biopsy. The fluid was very less. And for example, in suspected mesothelioma, when the pleura is very like fibrosed and hard, and you have semi-rigid with you, instrument with you, you are not able to take proper biopsy samples where you need deeper samples from the subserosal level. So in those cases, you may get negative samples where you may still remain inconclusive. The patient may, there might not be proper anesthesia, sedation, the patient was non-cooperative. And so there are few, these are the circumstances where your medical thoracoscopy may fail. So to improve the yield of thoracoscopy, first and foremost, I would say that pre-procedural ultrasound is very, very important. To know how much is your fluid, whether they are thick adhesions or not, which instrument you need to. Pre-procedural selection of the instrument is also very, very important. If you have thick adhesions are there, anticipating that you may, if you have that legacy of having both the instruments, you may opt for the rigid thoracoscope. And having the ultrasound throughout the procedure is also very important. Then proper sedation and analgesia is also important so that the patient is also cooperative, because we are doing under moderate conscious sedation. So patient cooperation would help you to take proper biopsy samples. If the pleural space is less, the fluid is less, you may have a pre-procedural preparation to insufflate the air to have proper pleural space. So another thing is proper inspection of the pleura is also very, very important to get the proper biopsy samples. The systematic approach, going to all the areas, the costal areas, apical, diaphragmatic, and proper removal of the adequate removal of the fluid so that you are able to see all the pleural space and take the samples from the desired space. And apart from that, to increase the yield, then Dr. Munawar sir has already mentioned that we have newer thoracoscopes where the angulation is 180 degrees. You may have the areas biopsied from along the trocar. You may use narrow beam imaging, which may tell you about the vascular areas. You may have further advanced techniques of confocal autofluorescence is there. So where you can target the specific areas. So these are the things which we can incorporate if possible to increase the yield for thoracoscopy.
Thank you, Dr. Shweta. Maybe sometimes we have started using imprint cytology at the
yes, frozen section. Yes, yes.
In your bronchoscopy or thoracoscopy suite, we start doing it. So maybe that may help you
yes.
to decide that you have enough sample, because
yes.
inadequate sample is one thing which we always, none of us like it. So doing an imprint cytology is not very difficult.
Definitely,
and unfortunately, that has not taken off very well.
Mm.
But I believe that's something which can really help if we have the facility for it. Thank you, Dr. Shweta. Now we move on for the next question to Dr. Arpan. Would you repeat thoracoscopy in case of failure to achieve the diagnosis? If yes, when?
I think yes, we would, of course, but that number of the percentage of those patients are very less. Dr. Shweta has almost pointed out everything that had to be told. So I'm not going to repeat all that. But a couple of things I think I would like to point out here is that in such cases, if we at all need to go for a repeat thoracoscopy for achieving the diagnosis, what we have started doing off late in last 3 to 4 years is we have started using cryobiopsies, cryoprobe to take that biopsy. I think Dr. Munawar sir can also elaborate on that. But last 3 years, 3.5 years, we have started doing that, which is practically increased our yield to a significant level. So that is one thing. And for all those people out here who have come across that thing, the only thing I would like to point out is that whenever you're going for a repeat thoracoscopy, try to remove the chest drain on table at that particular time to avoid the adhesions along the tract. That is one thing that I just want to point out here. Rest of all the things, I think Dr. Shweta has covered up for that thing. Munawar sir, can you just elaborate if your experience on using cryo pleural biopsies?
Yeah, again, a very useful technique because you get a bigger sample. And if you do not have, if you have cryoprobe, it is, and if you use to the cryoprobe, then you can potentially use that to enhance the diagnostic yield. Again, as you mentioned, checking and having access to frozen section or imprint cytology or something like that would be extremely helpful. Having said that, the biopsy forceps, the bigger biopsy forceps now that we use for the semi-rigid scope, of course with the rigid scope, if you take full thickness biopsies, those often are good enough. An alternative is to use the cryoprobe, relatively safe cryoprobe, particularly if you check the vascularity in advance with narrowband imaging, it makes it even safer.
Thank you, Dr. Munawar. I think we have covered most of the stuff in this question. Now we move on to our next question to Dr. Vijay. What are the common complications and pitfalls of thoracoscopy in undiagnosed pleural effusion?
Yeah.
Dr. Vijay?
Sushil, that is one very, very important practical question. See, the most important thing step in thoracoscopy is to gain safely access into the pleural space. That is the first and most important aim for us. And if you finish that, if you gain access into the pleural space successfully, yes, your job is almost 90% done. So coming to what the beginners, they do, the mistake is using an ultrasound. They do the ultrasound a day in advance or the morning of the procedure, but they don't use the ultrasound while placing the trocar. So that is very, very important. They must, most of us, okay, when they are in beginning of their career, they may do this mistake. So it should be avoided. As Dr. Munawar sir has rightly said and then showed in his videos, it should be done, ultrasound should be done on bedside when you are starting the procedure. So that, so if you do this, then we can avoid false track. And sometimes what happens is we may injure the diaphragm and very rarely the liver and spleen on the left side as well. And second, we must remember what is the purpose that you are going inside into the pleural space. So once the pleural space, once the purpose, you went inside to get the biopsy. Yes, finish that job and come back. Don't play around there. So if you, once the job is done, example, you need to do a biopsy and then you have done a pleurodesis and then come back. But many a time, so it is very exciting to venture into, you may see a very good rounded pleural nodule on the visceral pleura. So on the token, what will happen is beginners may start venturing biopsy onto the visceral pleura or getting into the close to the mediastinum, getting into the close to the apices of the lung, where there is a neurovascular bundle is there, subclavian artery, subclavian vein will be there. Please, please do not. I don't recommend, at least once you get at least 100 cases of experience with, then only you can go into that places. But strongly, I believe not to venture to get into close to either subpulmonic or close to hilum or into the apices. And Next, lack of, as Dr. Shweta rightly said, lack of a diagnosis. It will also lead to. So the common mistake what beginners they do is, so once they enter into the pleural space in pleural effusion, undiagnosed pleural, they don't aspirate entire fluid. So without aspirating entire fluid, they try to look into it to get the biopsy. So sometimes there may be only very few nodules in the lower part of the chest. So if you don't aspirate entire fluid, you will end up in missing the diagnosis. And the most important complication that we fear as a pulmonologist is bleeding. I think last module, Dr. Sandeep has shared my video in the webinar, so which showed the bleeding can occur at any point of time. So as I was presenting in my presentation, as I was saying, it is very, very important to keep your thoracic surgeon in and around the OT area while doing procedure. Bleeding may occur in 1 in 100, 1 in 200, but if it occurs, it should not exsanguinate the patient, and you should not lose the patient on table. So what measures that you need to do? Dr. Sandeep has said, as I have shown in that video, maintain your calm and compose, and then make sure you have the at least pressure on the bleeding side with a gauge piece, so that the bleeding with pressure will be controlled. And then once the surgeon comes, you can hand over to surgeon. Or most of the times, if you can give the pressure for significant time, 4 to 5 minutes, all the bleedings will be controlled. Over to Sushil.
Thank you, Vijay. Now we move on to our next question to Dr. Praveen. How would you classify pneumothorax? Can you elaborate on that, Dr. Praveen?
Okay, so yeah. So we are moving on to pneumothorax now. So basically, pneumothorax means there is some communication between the alveoli and the pleural space, or the pleural space with the atmosphere, or some air gas forming organisms in the thing. So any of this can lead to pneumothorax. So we can classify in many ways, but the one thing is, if you look at the hemodynamic aspect, then probably we can classify it into a simple pneumothorax and a tension pneumothorax and an open pneumothorax. But otherwise, the most common classification is, which we have already discussed in our previous, by the previous speakers. And Dr. Vijay has already put it forward, that we can divide it into spontaneous and traumatic. And traumatic into an iatrogenic and a non-iatrogenic type. Non-iatrogenic means something like an accident, RTA, or road traffic accidents, or any penetrating lung injuries, etc. Iatrogenic, we all would have seen probably once in your lifetime at least, any sort of central vein cannulation, especially with the subclavian vein cannulation, the pleural tapping, lung biopsies, lung FNACs. All these can lead to iatrogenic. Like I had a patient who developed a pneumothorax after the liposuction for a breast reduction. So this doctor went in too much, and then it caused an hemopneumothorax actually. And then we have the spontaneous. We can divide it into primary and secondary. Primary means, as the name indicates, it's without much of a cause. We don't know the cause of it, but it's usually seen in a young, tall, thin males with no other significant comorbidities. Many a time they will be smokers. Usually it's said to be the rupture of the small bullae that is present in the lung. Secondary pneumothoraxes, classically secondary to any other disease. Like the commonest one that we see is the COPD, as severe asthmatics, interstitial lung diseases like sarcoidosis, LCH, LAM, infections like pneumatoceles, like in case of Staph aureus, pneumocystis, or tuberculosis. Then other conditions like bronchiectasis, lung abscess, those things, the lung abscess, cystic fibrosis. Very commonly in connective tissue diseases like Marfan's, Ehlers-Danlos, rheumatoid arthritis. Other causes like catamenial pneumothorax, then secondary to barotrauma, ARDS, and then barotrauma, which we very commonly see in thing. So these are the various causes of the secondary pneumothorax.
Thank you. Thank you, Dr. Praveen. Now I think we move on to our next question. Once you have a patient of pneumothorax, how you algorithmically manage this patient? What is the algorithm for management of pneumothorax? Dr. Shweta, please. This is the question for you.
Yes.
How
So-
you go stepwise in managing these patients? Can you brief it properly? We have
Yeah.
already discussed in our talks, but I think let us have it in a proper way. That what practically, how can you do that? So can you please elaborate on that?
So first of all, as what Dr. Praveen has said, we must classify the patient whether it's a primary spontaneous pneumothorax or a secondary, because it's important for the long-term management also. And what the recent change has been there in the BTS guideline is there to concentrate more on the symptoms of the patient rather than the size of the pneumothorax. Earlier, there was a demarcation of the size more than 2 centimeter, less than 2 centimeter. On the basis of that, there was a flow chart. But now recently, the more emphasis, irrespective of the size of the pneumothorax, the emphasis has been given on the symptoms, whether the patient is stable or not. Stability in terms of whether the patient is maintaining the saturation, patient is hemodynamically stable, he or she is not in respiratory distress, and the risk factors in terms of whether he has an underlying previously diagnosed underlying lung disease like COPD secondary, or the patient is the profession is such that which is high risk like the divers or the altitude. So if the patient we diagnose as a primary spontaneous pneumothorax and the patient is asymptomatic, or to say very mildly symptomatic, the first step is to observe the patient for the next few hours, maybe 4 to 5 hours, and repeat the chest imaging. If the pneumothorax is resolving or it has resolved, then you may discharge the patient and call the patient after 2 to 3 days for follow-up, and then after 3 to 4 weeks. But on the very first day, if the pneumothorax is increasing or the patient is becoming symptomatic, then in case of primary spontaneous pneumothorax, you may have to go for needle aspiration or the ICD insertion. And if we compare both of them, needle aspiration versus ICD, the recurrence rate is same. The long-term recurrence of the second episode is same, needle aspiration versus ICD. But obviously the needle aspiration is a lesser invasive procedure and the hospital says less. But you may go for either of these depending upon your expertise or the patient preference as well. So primary spontaneous pneumothorax basis of symptoms. And if we go for the secondary spontaneous pneumothorax, we know that most of these patients are COPD, they have underlying lung disease, they have already lung reserve is poor. Most of these patients are asymptomatic, they are in respiratory distress or maybe hypoxemic. In most of these patients, you may have to go for ICD insertion at the very first go. Small bore ICD insertions are preferred. And after that, you may plan accordingly whether you want to go for the pleurodesis, which may be medical thoracoscopically or VATS guided, or through ICD if there are no resources. And the second aspect of the management is whether to go for the surgery or not, when to go for the surgery at the very first instance. A patient of primary spontaneous pneumothorax has come to you and he has, you have to put the you have to have done the needle aspiration or ICD insertion. So BTS guidelines have clearly recommended that in primary spontaneous pneumothorax, surgery is not indicated in all the cases. Only few selected cases, like if the patient has recurrence, patient has second ipsilateral or the first contralateral, or if the patient has bilateral pneumothoraces, or the profession of the patient is such like diving or he or she is pilot. In such cases, or in patients of prolonged ALE, these are the cases where you have to go for the further medical thoracoscopy or VATS or even open surgical, depending upon the condition for the surgery, definitive therapy at the very first go. Otherwise, on the basis of symptomatology, you have to observe or needle aspiration versus ICD.
Thank you, Dr. Shweta. That was really nice. You have elaborated it very nicely. Now I move on for the next question to Dr. Munawar. In your practice, where would you keep thoracoscopy in pneumothorax algorithm? How you would consider thoracoscopy in this algorithm of pneumothorax? Would you keep it or you will not keep that at all?
Thank you, Sushil. Great question. And some of this has been addressed very nicely by Dr. Shweta Bansal. This is a subject of enormous controversy world over, and whether there should be an intervention, first of all. Secondly, who should be doing the procedure? Should it be a surgical VATS procedure? Should it be a thoracoscopic procedure? Should we do a blebectomy, bullectomy at the same time, or just pleurodesis? Does it make a difference? One of the reasons is we do not have clear evidence-based guidelines because of the lack of randomized controlled trials. There's no robust evidence. There's some evidence, without a doubt, to guide us, but there's no robust evidence. That's the reason. What happens is we have to be very practical. We have to be very pragmatic and think what is best for that particular patient in your practice. If you, for instance, in my setting, I have a very close collaborative work with the surgeons. So many of these patients, if they're fit for surgery, if they're fit for single lung ventilation, anesthesia, then they would go to the surgeons rather than to me, which is fair enough based on what is available. However, secondary spontaneous pneumothorax, patient with advanced emphysema, those who have not fit for GA and single lung ventilation, very occasionally I might perform thoracoscopy. Vast majority of even those patients, we would put in a chest drain and then do pleurodesis through the chest drain to sorry. One point to remember, or 2 points rather. First, what you do for these patients thoracoscopy or not, depends upon the skill of the operator. Now, Dr. Vijay Kumar showed beautifully how with his advanced skills, he's able to safely treat these patients with medical thoracoscopy. The first thing is the skill of the operator. Second thing, also to remember, is these patients can have quite severe pain because pleura, which is in pneumothorax, is exquisitely sensitive. The parietal pleura is heavily innervated, exquisitely sensitive. So patients are going to have very severe pain. That is also something you need to bear in mind if you do thoracoscopy or not, or pleurodesis. So a lot of analgesia, a lot of sedation is required for these patients. So I'm sorry, there's a lot of confusion, and it's all about a multidisciplinary discussion and see what is available to you. In my setting, most of those patients go to the surgeon.
Thank you, Dr. Munawar. You tried to at least make it a little simpler because it's a very complicated and difficult decision. And I think most of these patients land up with a surgeon, I believe. Most of the patients in our practice also. Thank you. Now we move on to the next question to Dr. Arpan. In patients with persistent pneumothorax and bronchopleural fistula, would you consider thoracoscopic or bronchoscopic closure, or you would send him to surgical management? I think that's an important question.
Yes.
Persistent leak, how you do it, how you approach.
Can you hear me?
When you consider doing a thoracoscopic or a bronchoscopic closure, and when you send them to the surgeon?
So as far as the BPF are concerned, I would like to tell you here, put forward one thing is that whether the BPF is central or peripheral, that is one thing, and the size of BPF, everything matters on these two things. See, for broader guidelines, any BPF less than 5 mm or we would consider to do a closure either by a sealant or a endobronchial devices. That can be successfully done in those cases, but only in less than 5 mm. For between those BPF which are between 5 to 8 mm, it's kind of a gray zone. You take your decisions on the table whether you want to go ahead with it or not. Anything above 8 mm, I think they are meant to go to the surgeon and you should not be trying. Only in those cases which are surgically very poor candidates, or maybe for a time being you can use it as a bridge to surgery, you can consider thoracoscopic or a bronchoscopic closure of BPF. But by and large, most BPF, at least in the Indian settings that we come across, are quite big. So I think surgical candidates, they would better be going to the surgeons.
But it's very difficult to measure in a collapsed lung. How you measure it? Many times it's not possible
like,
to measure.
By and large, I mean, with experience and seeing it, I think that's the only way out of it. I mean, you cannot measure. I fully agree with you. I mean, you've been doing a lot of rigids. I saw your paper right now. I mean, you send that, and you've been doing a lot of work with rigid scopies and stentings and everything. I think by experience, you'll practically figure out that how big it is, and probably it is. That's a gray zone area. I think again.
Okay, thank you, Dr. Arpan. I think now we move on to our next question to Dr. Praveen. Which cases of pneumothorax should straightforward be referred to a thoracic surgeon? What's your take on it?
Okay, so that was something which was addressed by Dr. Shweta too. So the primary aim of the surgical management is to identify and close or ablate the source of that air leak, like if it's a blood removal of the blood or resection or whatever it is, and also to, if possible, to make a pleurodesis.
The question is, sorry, Dr. Praveen, we want to ask you, which are the cases you directly send to surgeon straight away without fiddling with that patient?
I'm coming to that.
Answer we want from you.
I'm coming to that, yeah. So as it was already mentioned, if the patient comes with an secondary ipsilateral pneumothorax, or if the patient comes with an first contralateral pneumothorax or a bilateral pneumothorax, these are all the general indications for a patient to be sent directly to the surgeon. Similarly, if the patient has a profession which is at risk, like say a patient who and divers or a pilot, so these are all patients who are at risk, and or who the mountaineers, etc., etc. These are all patients at risk. So if these patients develop an pneumothorax, then preferably they have to. It's always better to look for any blood in them and then close that, and then do a pleural symphysis. So it's better to directly send them directly to an thoracic surgeon. So, and of course, this is not a primary indication like a persistent air leak. That's not directly going to the surgeon anyway.
Thank you, Dr. Praveen. Now we move on to our next question to Dr. Shweta. If patients have blebs or bullae seen on an HRCT, would you proceed with the medical thoracoscopy or you send them to a surgeon? What's your approach in this situation? Dr. Shweta, please.
So, at the very first go, whether we really want to go further for medical thoracoscopy or surgery or not, because if you have blebs which are cysts which are less than 2 centimeter in size, and if you have a patient of primary spontaneous pneumothorax who is young, who does not have any previous lung disorder, so in those patients, as Dr. Munawar sir has said, that there is still a controversy whether we really need to go further for the definitive treatment at the very first go or not. But if we really have seen that there are blebs on the CT scan, we need to know the number of the blebs which are there and what is the size. If the blebs less than 2 centimeter, which we call them, but if they are bulla which are more than 2 centimeter in size, in cases of smaller blebs, you may go for medical thoracoscopy, but that too in the hands of experts only, because managing these blebs through medical thoracoscopy, you may use argon plasma coagulation or electrosurgical procedures, followed by the mechanical abrasion through the medical thoracoscopies. This has to be done by experienced hands only if you have been trained enough in the medical thoracoscopies. In cases of the blebs which are small, localized, lesser in number, you may go for medical thoracoscopy. But if you have large bulla is there, you have multiple blebs on the contralateral side also, then it's always better to refer the patient to the surgeon and let him be in safer hands.
I think I agree that larger blebs, yes, send it to a surgeon. Smaller blebs, do we really need to do something about it?
Yes, that's what I was. That is what I was saying. It's not always need to be treated.
If the lungs have expanded, we can just, if at all you want, we can
Can I add a point here? Can I add a point? Yes, a very interesting discussion happening. So that's what I presented in my talk. So when we look at the fluorescence enhanced autofluorescence thoracoscopy, when compared to white light thoracoscopy, so the gross difference is the fluorescence is getting leaked all through adjacent to the
that is porosity of the pleura is there.
Porosity. It means lot of visceral pleura is not normal. So there is no point in just resecting a bleb and then doing the pleurodesis.
So what there has been
important is the evidence says that it's not the wedge resection that is important. It is even without wedge resection, if you can do a pleurodesis, creating a pleural symphysis, that is the most important thing. And as you rightly said, once the lung expands and then it adheres to the parietal and visceral pleura gets adhered, that is what is the task in our hand.
Yeah.
So that's
So
what
small
the
blood-
evidence says, that these blebs are not really maybe the cause for recurrence. These are emphysema-like changes, which in 30% of their studies, which have shown that in 30% healthy controls, they may be normal. They may not lead to pneumothorax throughout their life. So they need not to be treated all the time.
And another
That is
practical
what-
point, Dr. Shweta, here is when there is a multiple blebs you see, so in a younger individual, these are the patients, they may land in future because of diffuse emphysema process for transplant. So in those cases, never combine with talc poudrage, do a mechanical abrasion and come back as a pleurodesis of choice. If you do talc poudrage, what happens is the surgeon will find while transplanting him, we will find very, very difficult in creating and then explanting the lung.
Thank you, Dr. Vijay. Now we move on to the next question for Dr. Munawar. Sir, for semi-rigid or rigid thoracoscopy, which one you choose for a pneumothorax in case if at all you need it? You go for a semi-rigid thoracoscope or a rigid thoracoscope, and why?
Yeah, again, very nicely covered by Dr. Vijay and Dr. Shweta, some of these aspects which would answer your question, because depends upon what you want to do. If your plan is purely to do a pleurodesis, for instance, in somebody who's secondary spontaneous pneumothorax, not suitable for further interventions, not fit for surgery, not fit for anything beyond even like transplant, as alluded to, then a semi-rigid thoracoscope is sufficient. If you wish to do something more, if you're highly skilled, and then yes, if you want to do some advanced interventions that Dr. Vijay has described, maybe the rigid thoracoscope may be of help. But because this is a thoracoscopy webinar, I just want to reiterate a very important point, because the more you do for these patients with a thoracoscope, the higher the risk of complications. So the most useful aspect of thoracoscopy is to make a diagnosis. That is where we have maximum evidence. And there, thoracoscopy is completely safe or almost entirely safe if it's practiced in a safe, systematic fashion. As you venture into other procedures, you have to think, what are the benefits? What are the risks to the patient? Am I actually doing something which is evidence-based, which is a benefit, or am I increasing the risk? So when you go down this route with pneumothorax, that's why in the UK, very rarely do we do thoracoscopy. If we have to do, it doesn't matter so much whether it's used the semi-rigid or the rigid thoracoscope, unless you do advanced interventions.
Thank you, Tom. Thank you, Dr. Munawar. You have nicely elaborated about that. Either of them can be fine, depending upon the availability. And most of the time, you are sticking to diagnostic procedure. You are not going beyond that in majority of patients, and sometimes you do talc poudrage with it. So if even a semi-rigid would be good enough, which most of us do these days. So I think that's the answer for this question. Now we move on to the next question to Dr. Vijay. How do you monitor the patient after medical thoracoscopy, and when do you discharge these patients? What do you do in your clinical practice?
And Sushil Bhai, in clinical practice, it is very, very varied. We cannot generalize when to discharge. Let me first talk on when to discharge.
How do you monitor? Before that, how do you monitor these patients?
Monitoring is okay. First of all, as soon as the procedure is done, we'll shift our patient to the recovery area. In recovery area, patient will be there for 1 to 2 hours, and then we'll make sure that analgesia is covered properly and his vitals are monitored. We'll get an X-ray, within an hour, and then we'll review the X-ray. Once the X-ray shows complete expansion of the lung and patient is doing vitally stable, we'll shift him to the room. So that's what we do. And then, as I said in my talk, it is very, very important. Never, particularly when you are dealing with a pneumothorax kind of thing, never clamp the ICDs while transporting. It is a very, very wrong habit that many units they practice. Clamping ICD, and then sometimes they cap the Romodrain bottles. So this has to be, what I do is, as soon as I connect the ICD to the Romodrain bottle, I remove the cap and then throw it off so that it will become inaccessible, so that the tension pneumothorax during transportation can be prevented. And once patient is stable enough, when the X-ray shows lung expand, there is vitals are absolutely fine, then we'll shift him to the room. And coming to discharge, and we have a plan. If the patient is cash patient, probably we can do the case as a morning first case, and then monitor till evening, and then discharge the patient on the same day with the ICD. Okay, and then we'll call the patient, we'll train the patient attendants of how to manage ICD, and then call that once the tube drainage is less than 100 ml, subsequently on 2 days, then we'll call them, and then we can take off the tube. That's one thing. But if the patient is admitted under insurance kind of thing, and the cost is not a limiting factor in India, okay, so then we can keep them, and then the next day we will send the patient, will discharge. This is what generally we do.
Next day you usually
also
remove the
appreciate that.
One second. Next day you remove the ICD and next day you remove the ICD and send?
Yeah, next day when the drain is less than 100, we can do that, and or else we can. It's not uncommon to discharge the patient with an ICD. And we are living in an era of where the thoracic surgeons are performing tubeless thoracoscopies. That means they don't intubate non-intubating wards, and then they don't put a central line, and they don't put a Foley catheter, and then they don't put an ICD at the end of the procedure, and then they perfectly do a lobectomy and then come back and then monitor the patient. That is the era where we are living. So there is no, if there is not much of pleural effusion, then you can do that as well, and you can remove the tube in less than 24 hours.
Thank you, Dr. Vijay. Dr. Munawar, how do you practice in this situation? When you normally discharge the patient, do you do daycare thoracoscopy or you discharge the next day? How you normally do it?
Yeah. So if the patient is fit and well, otherwise, and the thoracoscopy is uncomplicated and the lung is dynamic, what we do is, after the ICD is placed, after 2 or 3 hours, we do a chest X-ray, check for complete re-expansion of the lung, then remove the ICD. If the patient is has all the support that is necessary in case of a complication, we would send him home the same day. However, if the patient is older, requiring more support, traveling from far away, because our service covers a wide geographic area, we would keep them overnight and remove the chest drain the next day, or sometimes remove the chest drain the same day, but monitor them overnight to make sure that they are fine. One of the practical things that I have done in the last few years, I don't know how many of you put in a suture when you remove the ICD. Do all of you put in a suture? The wound?
Yeah.
No, we don't.
Okay.
No, we
So
don't.
what
I don't do so. We don't.
We don't.
No, we don't.
You don't.
We don't do.
Oh, okay. So I tend to use a glue when you remove the ICD, a nice glue and a firm dressing, and that has also helped us because otherwise you have to put in a stay suture before, and then you have to arrange for the suture to be removed by somebody after a week or whatever. So this has also been helped. The reason I started doing that many years ago is I had a doctor that I performed a thoracoscopy on, and the doctor, after on the follow-up examination, told me that the worst thing about the thoracoscopy was the placement of the suture after removal of the drain, because obviously that time there was no sedation, there's a little bit of local anesthesia, and a junior doctor placed the suture. And I thought about it and started switching to glue, which has been very good. So just a practical point to remember.
Thank you, Dr. Munawar. Now, I think we have covered most of the questions. Anything you want to add, Dr. Munawar, to this? Dr. Munawar, please, can you want to add something to this? We have now almost to the end of the this webinar. So
I just, we have discussed so many things in this webinar, and so beautifully presented and discussed by everybody. And because there's a huge audience, I'd like to emphasize the fact that thoracoscopy is an incredibly important technique if it is properly learned and safely practiced with the use of ultrasound on the table. And then, as Dr. Vijay quite rightly mentioned, not to get excited when you're inside the pleural cavity, limit to what you want to do, the safe area and the costophrenic angle, where most of the gold is generally for thoracoscopy. If you limit to that and follow the algorithm, which you have very nicely described, you're going to benefit all the patients. You're going to get an accurate diagnosis vast majority of the time and plan the best possible treatment.
Thank you, Dr. Munawar. Dr. Vijay, any words of wisdom from your side before we end this webinar?
One thing we must remember is every intervention, should be very focused, very meticulously planned and then executed very well. So what my teachers have said, Professor Arvind Kumar sir, sir has said very clearly, the procedure has to be planned and then completed in your mind a day in advance at least. So please practice and then meticulously and execute meticulously. As said again, I am reiterating, don't venture into unknown areas. That is not your job. You are a pulmonologist. Be a pulmonologist. And I just want to tell a story of, quickly in 1 minute, one of my friend who started his practice almost along with me 16, 17 years back. And then his first case on table bled torrentially. So then I'm telling you, Sushil, he is yet to start his second case. So please don't venture into, it is not about your boldness or something. It is patient safety is the most important thing in practice.
We are not made for that. We are not made for that.
We are not here to experiment. We are here to learn, grow, and help our patients. So please be very careful while starting your practice. And then at least initial 25-30 cases, you should do under someone else and then get enough experience and then move on. Thank you, Sushil, for wonderful moderation.
Thank you. I would ask all the panelists anything they want to add to this talk. All the three panelists.
Dr. Vijay nicely said. So in a nutshell, watchful waiting is what is required at times. Just because there is a saying with the bronchoscope, the same saying goes with the thoracoscope as well, right? Here you will be stuck if you mess up into selecting a patient initially. So watchful waiting is what is always required at times.
Thank you. Dr. Shweta?
And
Dr. Shweta or Dr. Praveen, anything you want to add?
I would like to add that learning ultrasound is also one of the backbones for doing the pleural procedures. Ultrasound is a very, very important tool.
It is very important. Now we do, every patient, we do an ultrasound of a pleural case. So normally every patient. So we need to learn and we need to practice it. A very important aspect of before doing any pleural procedure, you need to really have an ultrasound bedside. That's very important. Normally what we do is one day before we do an ultrasound, so that we know that this is the right case for case selection. If there are too many adhesion septations, we may, and we think that this is difficult for us, we may not venture at all. And if at all, if there's a very small pleural effusion, then probably we may or may not do it. Probably we may not do it. And only if we feel that this is the right patient day before, then we do it next day on table. So this is what we practice, Vanessa. And now all our residents have been trained, they do it themselves. So it's very easy now and it's much safer. So I think learning ultrasound is very important, which all of us should do before we go ahead with advanced procedures in like thoracoscopy and others. So thank you, Dr. Shweta. Anything you want to add, Dr. Praveen?
Yeah, and the last thing is when we for a beginner, it's always stick to taking biopsies alone. Because as it's already mentioned, that is the prime aim of doing a thoracoscopy. Looking at it and taking a biopsy, because that's one area where we have the strongest indication. The rest all are an extension of it. So before venturing into others, make sure that you have done enough scopies and have done enough biopsies and then got experience in first hand. Then only you need to venture into the other ones. Thank you.
Important thing is stick to parietal pleura. Don't venture into visceral pleura. I would practice it. I prefer to just stick to parietal pleura. And I think that's the message everyone should get, that stick to parietal pleura. Don't try to venture into vesicular pleura. You are not supposed to do it. You are not the right person for it. So, and yes, enough number of biopsies, very important. And one important thing is, in India, we have a lot of time, we have a problem in the differential diagnosis of TB versus malignancy. So just don't do the biopsy, but also don't send it for histopathology alone, but also send for TB culture and gene expert in the tissue. That's, I think, very important, because in India, a lot of time we have a problem with that. And I think we should do it in most of the patients when you have a diagnostic dilemma in such situations. I think now we end up our talk for today. And thank you, IAB, for giving us such a wonderful opportunity for having this webinar today. I now close the webinar. I ask my audiovisual team to proceed further. Thank you.
Thank you. Thank you.